I mean, we all know that sound carries through air. It's just the speed of it differs. But all medical devices are designed in a way to interpret that the speed as if it's going through the water, roughly, or biologic tissues. Because of that, it's impenetrable to medical ultrasound. So to orient you here, I'm not sure if it's perfect, but the only real thing you see is this. Everything below that line is fake. All of this is fake. All you see on the screen is fake. Probes. We can use any of those probes. We can use phased array pretty much for everything. We can use linear probe pretty much for everything. We can use linear. Linear, the only problem is we may not be seeing, let me go back. It doesn't penetrate deeply, so if we're looking for pleural effusion, it may not be reaching far enough. So it may have its own limitations. But we want to see pleural line at very high resolution. Linear probe is wonderful. So in this example, we use linear probe, and that's how the landsliding looks. Remember again, this is the real thing. This is all fake. So pleural line is right here. And there are two ribs, right? There is one rib here. It will give a shadow because it completely blocks propagation of ultrasound. And the rib shadow on this side. And if you pay attention to this line, you can see as if it's moving. There's lots of motion here. And there is lots of motion, small motions and bigger motions. And we'll get into that in a little bit. So that's how landsliding looks like. So that means lung is up and there is no pneumothorax. It will immediately rule out pneumothorax. As I mentioned, those are the ribs, right? That's periosteum. Then we'll give artifacts. That's pleural line. And that's what the motion looks like. That's what happens. Visceral pleura grinds sort of against the parietal pleura. What are those things? Remember we said anything below pleural line are artifacts, right? Fakes. A lines are also fake lines. And they don't exist in real life. So what happens, it's a reverberation artifact. The beam gets here and bounces between pleural line and the probe. If it does it so once, or actually twice, it will think that the pleural line is deeper, and it will place something here. If it does it 3 times, which it does, because it's a very strong reflector, so it's like a mirror. So it will sort of trap that beam, and it will bounce twice, 3 times, 4 times, 5 times. You can see it even more sometimes. And A lines you should be able to see in everybody, unless they're completely erased by B lines, which we'll talk about in a second, as long as the probe is completely perpendicular to the chest wall. If it's not perpendicular, you may not see those A lines. So it's one of the quality indicators for doing lung ultrasound. Making sure that your probe is perpendicular, then you will see A lines. And we will see that when you practice. A lines stand for air, right? So it's usually a normal lung pattern. Good lung sliding, lots of A lines, that's normal lung. So what happens with pneumothorax? Let's look at it. Look at the pleural line here. You don't see that motion that we were talking about. There is no lung sliding. But in itself, that finding is not good enough. That's what we said. But other things, pneumothorax can generate A-lines. It's just not deep enough. You see, there is no twice distance will be here, right? So we're just missing A-line. But A-lines will be present because A stands for air. Pneumothorax is air also. There are no B lines, which we'll get to. And in pneumothorax, you will never see B lines. So presence of B lines will rule it out. There is no lung pulse, which is much smaller motion compared to lung sliding. Lung sliding is breathing. Lung pulse is heart beating. And when heart beats in the chest, it displaces the lung. It also creates this motion, but much smaller in amplitude. No lung pulse, no B lines, no lung sliding, and finally lung. So those things, presence of those will rule it out. Presence of lung point will rule pneumothorax in. Let's look at it, right? So, but it's poor specificity, overinflation, emphysema, etc. Pre-op exam. But let's look at lung point though. Remember I said if you see lung point, you can rule pneumothorax in. Believe it or not, we can teach it on a healthy person because the very edge of the lung, where it attaches, where it's close to diaphragm, by coming in and out, creates the same appearance you would see with lung point. So we can actually teach that. How does it? That's just to orient you. That's pleural line, and you see no lung sliding here. Look in here. You see something sliding here, nothing sliding there. That's, point out again, those are A lines. A lines. Presence of them will be also apparent in pneumothorax. And that's the precise position of that lung point. When lung point comes in and out. That's what happens, right? Pneumothorax here, pneumothorax there, right? So as someone takes a breath in, lung expands, there is lung slide. When someone takes a breath out, lung pulls out, and there is no lung sliding anymore. So you will sort of see this edge of the lung coming in and out. So when compared to chest X-ray, and more so importantly to CAT scan, lung ultrasound performs really well. Because in this study they compared chest X-ray and lung ultrasound, compared them to CAT scan. And you see how bad a chest X-ray, 52%. If you see it on chest X-ray, you know it's for sure there. But if you don't see it, you may be missing it. And now lung ultrasound will pick it up where X-ray pick up. The other thing that this particular analysis showed, that operator seems to be associated with accuracy, right? So if you're an experienced operator, you've done a lot of them, you will pick it up. But to get there, you need to do it repeatedly. Now we're coming to B lines, right? So remember, that's for reference, that will be almost normal, right? There is A lines, and there is one vertical line. And here you see many vertical lines. You see the flora, there is some lung sliding, but it's relatively minimal. And you see many vertical lines which start from the pleural line and go all the way down. And you can count them. And the way I usually count them, I see that they start from pleura, I go to the bottom, and I count them at the bottom. Because if they don't go to the bottom, they are not B lines. So it's 1, 2, there's another one here, it's just not as well apparent. 3, 4, 5, this one is probably coalescing, so at least 6. So it's more consistent with pulmonary edema if that person did not have any B lines before. You just have to take clinical context into consideration. Same can look like if you have ERDS or early pneumonia or something. It just means there is more fluid in the lung, right? What kind of fluid? Is it just water in CHF? Or it's inflammatory fluid as in ERDS or pneumonia? It's your clinical judgment to tell you. Remember we mentioned lung pulse. You see? It's with heartbeat. Much more frequent than this landsliding. And the amplitude of that is small. So, and when we started using more of the linear array probe, we actually see it much more frequent because the resolution is so good. You can actually differentiate those two motions. That's what Emont see. You have EKG, and you can see it synchronized with the heartbeat as opposed to respiratory cycle. And now look at how it looks with the respirations, right? Just to show the difference. So you have many small movements and amplified during the inspiration. Those are B lines, right? And again, that's a summary. As we said, origin and visceral pleura, so they start at pleural line. They are hyperechoic because they're bright. They synchronize to pleural movement, so they move with pleura, and they fade out A lines. So you see this sort of A line here, but it's erased by B line. If you really, really look at those B lines, you see that they're composed of multiple parallel horizontal lines. It's just the reflector is not anymore pleura. It's like small lung lobules, where is also connective tissue. They just serve as multiple reflectors. So because of that, the distance of between the different reflectors is much smaller. So it gives you those appearance. They actually have a name. They're called J lines. So that's what I mentioned. That's the mechanism. It just reflects from much smaller interlobular spaces. And all it means, there is more water in the lung. So the more water you start accumulating in the lung, the more real images. So the fake portion will start fading out, and you start seeing more real images until like in pleural effusion, which we'll see momentarily. We see real fluid, which is dark, anechoic, and a bright lung. So lung either full of water or just shrunk, and it's like a lactatic lung. Now all of a sudden you see the real tissue of the lung. So minimal fluid over there, more fluid here, even more here because there are more and more B lines, and then completely replaced by fluid. So if it's just a CHF patient, this will reflect stages of worsening pulmonary edema. Or if you diuresis, you can see things getting better. So to summarize, right, ultrasound is actually good for lungs as long as we understand what we are looking for. Pneumothorax can be ruled out easily. More difficult to rule it in. But it comes with experience. Someone needs to accumulate experience. It outperforms chest X-ray, but again, operator dependent. Pulmonary edema can be diagnosed and is easily distinguished from COPD exacerbation, for example. So COPD exacerbation will just look potentially as minimal movement or even sometimes no landsliding, but no B lines. Even without echo, we can look at clues between cardiogenic pulmonary edema and non-cardiogenic pulmonary edema. What you're going to look at specifically under those circumstances at the pleural line itself. If it looks like a jigsaw, it looks like small consolidations. it just looks diseased, it doesn't move much more likely non-choreogenic or ARDS. If it's completely smooth, bilateral, everywhere looks the same, that's choreogenic. Okay. Lots of references here, and thank you very much.
Thank you.